My name is Bill O'Neill. I'm the medical director of the Center for Structural Heart Disease at Henry Ford Hospital in Detroit. I think that Edwards actually got surprised by how quickly they've got approval for the S3, and so they haven't really been able to stock up sufficiently to meet the demand, and I think they've had a limited release. They started first with the partner sites, the ones that had previously been doing research with them so that they were experienced with the valve, and then I think they're going to roll it out to the commercial sites. I don't think that the valve is really commonly available. I think there's probably only 1 or 2 hospitals in Michigan, for instance, that have the S3 valve right now. Right, the valve is quite a bit different than the Sapien XT. First of all, it is lower profile. The way that they've designed it to fit into the sheath now allows 14 French sheaths to be inserted for most of the valve. So that's going to really limit vascular injury. Secondly, the frame itself is quite a bit different. The struts on the lower half are actually somewhat wider than the struts in the upper half. So when the valve expands, it expands asymmetrically. The lower part of the valve moves higher and the upper part doesn't move. So positioning the valve now becomes a little bit more interesting. They've done a very nice job of putting a positioning marker right in the middle of the valve. And so the concept is to use the annulus and then get the middle position marker and put that marker right at the annulus. It really makes deployment of the valve quite a bit easier. For whatever reason, the valve doesn't move very much when we deploy it, so we really had to limit the amount of sort of finagling that we do while the valve is being implanted. And then probably most importantly, the lower part of the valve has a skirt in it, a cloth skirt on the outside, which allows contact with the annulus and has really dramatically decreased the incidence of paravalvular leak. Well, it's actually changed our practice, Steve. We used to do all of these patients under general anesthesia and use transesophageal echo because if we had a leak after a valve implant, we had to figure out whether it was paravalvular or central, and so echo was a real requirement. Now that the valve doesn't really have any leak, we don't have to use transesophageal echo, so rather than using general anesthesia, now we're using conscious sedation. That's really dramatically improved the throughput in the laboratory. It takes typically 2 hours to do a case from start to finish, as opposed to 4 hours while we use general anesthesia. The patients recover quicker. We're getting them up in the chair that evening and they're walking the next morning. So routinely we're getting the patients home within 36 hours of the valve implant. So all of those practice changes have really simplified the procedure and made it much easier for patients to tolerate. As a result, there's going to be a push to try to treat lower and lower risk patients. Well, unfortunately, the technology has kind of overstripped or overstepped the bounds of reimbursement, and I think the reimbursement is really what's driving the process right now. The CMS for the condition of approval has only approved the valve for inoperable or medium to high risk patients. If the patients are intermediate risk, then the only way to get access is through a continued research registry. And if they're low risk, then there's really no treatment option available. So if you're 75 years old and a man and otherwise healthy, the risk of heart surgery is probably 1 or 2%. And those patients simply don't qualify. CMS won't reimburse for that. So we still are obligated to do open heart surgery or valve replacement surgery on a significant number of elderly patients with aortic stenosis. At the end of the day, you're going to have physicians and hospitals that are very experienced with the Sapien device and physicians and hospitals that are very experienced with CoreValve. And I think it's going to be sort of like Republicans and Democrats. You sort of are aligned to one, you're used to using it, you know how it works, and then you use that as the dominant valve. And I think that's going to continue for quite a while. I personally think that the Sapien currently, the S3 is currently a better valve because you get far less paravalvular leak. there probably will be an increased incidence of complete heart block with the S3. So that difference in the past, a core valve had a higher degree of heart block. As that implant technique is improving, the amount of heart block is decreasing, and the heart block, I think, will increase with the S3. So that's not going to differentiate very much. At the end of the day, I think that operators are comfortable with one valve, and they use that, and I think that's the proper approach. I don't know whether or not there's going to be much of a change in market in the U.S. Because I think most of the physicians are kind of used to using one valve and will use that as a predominant valve. The finances, I think, are quite tricky. It takes a lot of resources for an institution to have a TAVR program. You have to have a TAVR coordinator. You're obligated to fill out the TVT registry, and most hospitals require at least 2 FTE to do that. And the organizational process of getting physicians, surgeons, and non-invasive cardiologists together to do these procedures is quite a logistical challenge. For high-volume institutions, places that do more than 100 TAVRs a year, I think you can kind of offset those overhead costs by the numbers of procedures that you do. I think the places that are going to struggle, honestly, are going to be institutions that do less than 50 TAVRs a year, 1 a week. And in those places, all of the effort and trouble and organization, I think, aren't going to be surpassed by the finances. On the other hand, institutions kind of consider this a mark of a sophisticated center, and a lot of places are going to be doing it even if they lose money for marketing purposes. Yeah, that's the question about embolic protection, I think, is still a little bit open. If you take a look at the actual incidence of major stroke, for most centers, it's around 2 to 4%, so it's relatively low. You really can't predict who's at high risk. It would be really nice to be able to say you're a really high risk or a really low risk for an embolic stroke, and there's just really no way to do that. So I think people are going to struggle, because are you supposed to use these devices in all of the patients or just in a selected few? So we really haven't come to that point yet. There are a couple of ongoing trials in the United States with embolic protection. We're involved with one of them. And the devices are really pretty easy to use. It adds about 15 to 30 minutes of procedural time. So then the question is going to be, are you willing to add another 30 minutes to the procedural time to try to decrease an event which is actually relatively low rate? Sure, Steve. I mean, before disclaimer, I am a company officer for Neovasc, which is one of the leading mitral valves, and I obviously think that's a great valve, so I won't comment on that valve. But the other valves, there's been a flurry of acquisitions this summer. Edwards has now bought Cardiac Q, and so I don't know what they're going to do with their own internal Fortis program. But Cardiac Q has had a number of successes, and they're actively deploying valves in Europe. Tendyne is a very interesting valve, and again, I have no conflict with that valve. It was recently bought by Abbott. I think that valve is very unique, and they actually had a large number of implants that are already going on. I've talked with operators that use that valve, and it's really been quite stable. And Neovasc has had trials primarily with John Webb's group in Canada. There is a U.S. trial that has started. I think those are the 3 leading contenders. Recently, 11 was purchased by Medtronic. Medtronic, I think, has shelved their own internal program, and they're going to be going with 11 as a new mitral valve implant. So it's early days. I think they're all kind of early and competitive, but there's a flurry of activity. And I think probably we're in 2015 with the mitral valve where we were in 2005 with the aortic valve. So we're about a decade behind, and it's going to take at least a full decade before we really know how good these are, how durable they are, and whether they're going to take over surgical mitral valve replacement or repair.